recorded.
All right.
So we'll just give a minute or so to let folks start to file in.
Yeah.
Good evening. Thanks for everyone for being here. A couple people are filing in, so we'll just give it about 30 more seconds and then we'll get started.
Yeah.
All right, I'm going to go ahead and get things kicked off. Pleased to have our wellness webinar tonight on opioid use disorder with Dr. Marquette. He is our director of medication assisted treatment program. He's a hospitalist and he also works over at our community health center. And just a reminder that if you have questions that come up during his presentation, you are welcome to ask them in the Q&A box at the bottom or in the chat box. And I'll help facilitate that at the very end of his presentation. So I will hand it over to Dr. Marquette. Thank you so much.
Thanks, Natasha. Okay, so I'm Jacob Marquette. She already kind of introduced my roles, but tonight, thank you guys for coming, and we're going to talk about opioid use disorder and really kind of what's available here in South Lake Tahoe and a bit of the background. Okay, so kind of business stuff. I have no relevant conflicts of interest, and the views and statements expressed are solely my own and should not be interpreted to reflect official policy or position of any entity. All right, so a little bit more about me. I was born in Trinidad, California, a pretty rural area up north. I was a banana slug, went to medical school out in Pennsylvania, and was able to train at Ventura County in family medicine, and then have been at Barton here about a year. My wife is also a physician. She was born at Barton, grew up in South Lake Tahoe, and it's pretty tough to convince someone that grows up here that there's other places in the world to live. So naturally ended up back here, and we both really wanted to kind of return to the rural communities that helped raise us and be able to kind of focus our careers around that and take care of those people. Okay, so a couple goals for tonight. We're going to talk about defining opioid use disorder and some of the related nomenclature. I'm going to mainly talk about the evidence-based treatments and kind of what those look like. I'll give a quick synopsis of the national, state, and local response to opioid use disorder, which I think should be pretty helpful. And then just a quick review of the current literature and some really important perspective pieces that have come out in the past kind of few months to few years that are really changing kind of how we think about this. Okay, so with all medical lectures and talks, I'm gonna start off with a case. So this is Lucas. He's a 28-year-old male. He's got a history of opioid use disorder, alcohol use disorder, anxiety, and depression. So he grew up in South Lake Tahoe, played soccer for the Vikings, ski raced for the Foundation, and during high school, he had mild alcohol use disorder and intermittent use of prescription opioids. So not far off from quite a few people in this community. Okay, so just to start off with a few of the numbers. These are from 2016, basically, kind of when the data was compiled was in 2017. This was when overdose took over as the leading cause of death of people below 50 years of age in the US. And it has since only worsened. So this is kind of a breakdown of those numbers. 130 people die from opioid related drug overdoses a day. This is, like I said, only gotten worse since this time when these numbers came out. So we're now at a point where we're seeing closer to around 220 deaths a day. And the numbers from 2020 are closer, well, above 80,000 deaths, as opposed to that kind of 45 number. Okay, so when we look at this is going to be from 2019. This is the CDC data. So looking at main cause of death for people 1 to 50, it's going to be unintentional injury. As you can see, cancer, heart disease, suicide, homicide, all fall well below this number. And then if we break that down a little bit further, we get to see poisoning. And then if you look to the right, poisoning broken down into basically narcotics as the number one in that sort of cohort there. So this is just a quick statement that was put out from the Department of Health and Human Services. And this was 2020, obviously kind of like the era of our pandemic. And with that, we saw a very sharp increase in these numbers even further. So this is the 81,000 overdose deaths that I was talking about. That was an 18% increase from the previous year. And that ends up being around 220 deaths a day, like I said. Okay, so this is looking at sort of when we talk about numbers for opioid related deaths, we're mainly talking in number per 100,000 people. So we can see that our rural areas here, kind of Humboldt, Modoc, Mendocino, those are disproportionately affected when it comes to opioid related deaths. So that's really where the California Department of Health and Human Services has kind of focused their actions. Okay, so let's start breaking down into some of the definitions. Opioid use disorder is a DSM-5 diagnosis. So that's what our mental health diagnoses fall under. And I'm not going to read all the numbers to you, but it's a problem of using opioids relating to sort of how that affects your life. To meet the DSM-5 diagnosis, you really just need to have 2 of these on the list here. But those are all ones that you guys could think of if you were thinking of someone who uses opioids and how that's affecting their life. Okay, so people that have opioid use disorder, they then qualify for some of those evidence-based treatments that I talked about. That's going to be buprenorphine, methadone, and naltrexone in the US that we use. There will be various formulations of these, but these are the 3 core medications that we're going to be using in the hospital, in the emergency room, in the clinic. When I say adjunctive medications, these are ones specifically to symptoms of withdrawal. So that's like Tylenol for pain, and we'll kind of break down those ones later. Okay, so medication-assisted treatment, it's, as I was kind of talking in our preamble before coming on, it's not a great definition at this point. It's so broad that it doesn't seem to really apply to anything. But when we're using the definition medication-assisted treatment, or MAT, what we're talking about is use of those 3 medications in combination with some sort of counseling and behavioral therapy, whether that be dialectical behavioral therapy, cognitive behavioral therapy, preferably with a substance use psychologist. But there's also good evidence that if you just use medications alone, that's still very efficacious and is not having access to a substance use psychologist is not a reason to not prescribe these medications. Okay, so here's some visual representation of that. So don't get too bogged down in the words, but medications, counseling and behavioral therapies, calling it a little bit more of a whole patient approach. Okay, so I think we're going to compare this to sort of what's been done in the past, namely sort of abstinence as a treatment form. And so when we talk about benefits of MAT or MAT, it's reducing the withdrawal symptoms or eliminating those completely. We're going to really try and reduce cravings for opioids. And then all the medications that we're going to use block the euphoric effects of opioids. Not so much alcohol, but they block those in a way that sort of will reduce the cravings, plus if they're taken, not sort of have the desired effect. And then over time, there's good evidence that this does help sort of normalize the brain chemistry, the drives and motivations to sort of like basically steal to use and other things, and helps sort of redirect that motivation back into sort of bonding and things that are helpful for everyday life. Okay, so I'm not going to talk so much about methadone tonight or naltrexone too much. The main one I'm going to talk about is buprenorphine and Suboxone. This is sort of our stalwart in the clinic and in the hospital of what we use as our pharmacologic therapy in MAT. So I think there's a few definitions in here, and then I'll have some visual representations right afterwards. So buprenorphine is an opioid partial agonist. So that means that it binds the receptors, specifically the mu opioid receptors, but does not activate them fully. So it binds, doesn't completely activate, and then it also has a very high affinity. That means that basically it has a very strong bond, and if there's something with a lower affinity, it would sort of kick that off the receptor and be able to bind itself. So there's different formulations of buprenorphine, and that's going to be, there's sublingual tablets, there's oral dissolving tablets, there's films. And so these are all something that sort of dissolves in the mouth. And this is really based on the pharmacokinetics and the bioavailability. If it's dissolved sublingually, it's about 70% of the medication gets in. And if it kind of gets swallowed, basically it's going to be less than half of that. So when we talk about these medications, what we're really going to talk about is sort of like Suboxone equivalents, and I'll kind of get into that in a little bit. Okay, so here's kind of going through all three of them we'll talk about tonight: methadone, buprenorphine, and naltrexone. This chart just helps you kind of compare and contrast them visually. Buprenorphine has an excellent safety profile, not so much with methadone, but still a safer medication than most. And then naltrexone, we'll talk through that one a little bit as well. Okay, so another visual representation. On the left, we have methadone. So when we say full agonist, that means that it binds and fully activates the receptor. That's not completely true. I think most of these are in the 70 to 90% agonist range. I think fentanyl and sufentanil are kind of in that 90 to 95 range. But methadone is going to be what we consider like a full agonist, something that fully activates the mu opioid receptors. Buprenorphine, there's our partial agonist. Naltrexone is an antagonist, so it binds the receptor and completely blocks activation. So it has a very high affinity, and when we're talking about affinity, it's how strongly it binds the receptor. So it would kick both buprenorphine and methadone off of the receptor and bind. Okay, another visual representation, and I really like this one because it kind of shows the safety profile of buprenorphine. So when we see sort of dose-related effects along the bottom, and then that effect on the y-axis there. So this one is going to be looking at when we say buprenorphine is a safer medication, it's because it's going to not fully activate those receptors, the mu opioid receptors. And there, we'll see on the next slide, but they have activity not just in sort of our pain and reward centers, but also in our brainstem when we're looking at sort of respiratory drive. and that's namely how it's going to kill. So if it's only partially activating those receptors, it's not going to have the same respiratory depression and suppression that other full agonists like methadone and heroin would potentially have, so making it much safer. This also limits the euphoric effects because it is not the full agonist, so less chance of abuse, safer medication. All in all, like kind of where the future of this is. So these are some of those areas that I talked about. We have namely sort of nucleus accumbens and the VTA or ventral tegmental area, where we see reward pathways. We see on the bottom, the brainstem, that's our respiratory drive and our respiratory center. And there's also some areas of pain. So it's going to act on all of these, whether you want it to or not. Okay, so let's check back in with Lucas. So Lucas is now sort of had his opioid use disorder exacerbated while playing soccer for Santa Barbara Community College and UC Santa Barbara with recurrent knee pain. He has since finished college. He's returned to South Lake Tahoe, working construction, considering law school. His daily regimen is around 20 milligrams of oxycodone that he gets off the street. With rising rent prices and the street value, he began selling construction equipment and taking money from family and friends. His family gets rightly concerned and brings him into clinic. Okay, so the formulation of buprenorphine that we namely use in the clinic is going to be Suboxone. And Suboxone is a 4-to-1 ratio of buprenorphine and naloxone. And why do we use this instead of just using buprenorphine on its own? Well, we get sort of a higher level of safety. So we already talked about the partial agonist, that it is going to not suppress the respiratory centers as much. Also, it's not going to have the same euphoric effects as full agonists. And then when we combine it with naloxone, naloxone is the antagonist that we talked about that's going to bind but not activate any of the receptors. So when we do that, naloxone is not actually absorbed through the GI tract in any like clinically significant amount, or sort of like the mucous membranes. So if you take the 4-to-1 ratio of buprenorphine naloxone in a sublingual film, stick it under the tongue, the buprenorphine gets absorbed in around that like 70%, but the Suboxone, or sorry, the naloxone is not really absorbed through that mucous membrane, and therefore you don't get any effects of it. If it's attempted to be sort of redistributed and misused, they take the strip, melt it down, and attempt to inject it, the naloxone is actually active when it's done intravenously. So you not only get the naloxone blocking the effects of the buprenorphine that it was injected with, but also there's likely other opioids still sitting around in the system, whether that be heroin or methadone, something else. And the naloxone has a higher affinity for those receptors, so it will precipitate withdrawal. There's pretty well known kind of in the realms of people using this that it's something that will precipitate withdrawal, so it's not often done kind of anymore. Okay, Subutex is just buprenorphine. This one we really use in pregnancy because naloxone has teratogenic effects, so affects the growing fetus. So we try not to use it then. But we can also use this in people that have a very real allergy, namely anaphylaxis to naloxone, which is really rare. Okay, so we're going to walk through what an induction looks like. And so we don't use the nomenclature of induction when we start any other medication, but we use it with buprenorphine. And I think that's something that sort of increases the stigma and difficulty kind of wrapping the brain around starting to use these medications. And I think that nomenclature will likely sort of die out as things grow. But when we're talking about an induction, we're talking about either starting for the first time or restarting someone with opioid use disorder on buprenorphine. Okay, so when we're starting someone, whether that's new or recently relapsed, we want to ensure that they're in moderate to severe withdrawal before we start this medication. That's because we talked about buprenorphine being having a high affinity for the mu-opioid receptors. And so if there's still opioid hanging around in the system, whether that's oxycodone, OxyContin, hydrocodone, heroin, something else sitting there, this will displace that and put someone into what we call precipitated withdrawal. And that'll be elucidated a little bit more through a pictorial representation in a second. So we define moderate withdrawal of 8 on the COWS scale, which is the clinical opioid withdrawal scale. That's the main one we use kind of in the hospital, in the clinic, in the emergency department. That's roughly 6 to 10 on the scale, and we'll go through that. Okay, so here is that pictorial representation that I was talking about. And really this is sort of, if you bring buprenorphine in the system, it'll pull those full agonist effects down into that partial agonist realm, and that's experiences withdrawal. This is, you're still putting opioid into the system, but really to think about this, it's like you're driving 100 miles an hour on the freeway, and then you slam on the brakes to slow down to 55. You're going to feel that deceleration of 45 miles an hour that happens sort of instantaneously. It's going to be pressed against the steering wheel, face against the glass, like extremely uncomfortable. And that's how precipitated withdrawal is felt, like extremely uncomfortable. And it's something that, for all intents and purposes, we really try to avoid. Okay, so this is just talking about buprenorphine continuation when there's a break in treatment. If there's missed doses and there's no concern for opioid use in the interim, we can restart it at the same dose. If they've missed a dose, we have to go through this induction process again. Okay, so I'm going to talk a little bit more about the COWS and what that looks like, and we'll see it on the next slide here. So here it is. We rarely use it really in this form. It's now integrated into our electronic medical record system, plus there's numerous apps to use, but really it goes through sort of all of the classic symptoms that you think of when someone is withdrawing from opioids. So that's going to be tachycardia, so an increased pulse, sweating, restlessness, dilated pupils, bone and joint aches, rhinorrhea, tearing. Rhinorrhea is just runny nose, GI upset. In precipitated withdrawal, that's usually vomiting, tremor, yawning, anxiety, irritability, goose flesh skin, which is pretty obvious. So these are all the ones that we use. There's just basically a solidified scoring system for this so that we know that we're kind of getting someone that's in moderate to severe withdrawal. Or you can use the app. So this is the buprenorphine app, also known as the BOOP app. This one really goes through specifically not just using the clinical opioid withdrawal scale, but also how to do an induction at home. It's really what I prefer to use in the clinic with people that have a smartphone or a computer. They can use this one, and it's really helpful to sort of say, how do we start out? You get to log your doses in the app, and then it prompts you when you're going to take your next dose, plus off of that symptom scale, and it's all integrated into pretty much one seamless area. Okay, so as things have kind of grown and addiction medicine and treatment of opioid use disorder becomes more broad-based, UCSF has been subcontracted from the California Department of Healthcare Services to provide access to addiction medicine physicians, nurse practitioners, and nurses that are really well versed in using these medications And this is the service that's provided to all physicians and people in California. And it's now 24/7. It pretty recently changed that. It was 9 to 5. Okay, this is what I want to hit on because these things have been changing rapidly how we sort of do an induction when we're starting someone on Suboxone. So do we do that in the home or do you do that in the office? I think classically this would be done in the office. Even when I started training, a lot of times you would have someone come in, they would be in mild withdrawal or even moderate withdrawal, and you would want to say, okay, we need to start Suboxone. You would have to write out a paper script, hand that to the person. They would have to go to the pharmacy, return for a visit, all the while feeling extremely uncomfortable, and then be able to get graded in the clinic on the TALs. And so they'd come into moderate to severe withdrawal, kind of that 6 to 10 range. They would take the first dose. They would still be in moderate withdrawal. They would be out in the waiting room for about an hour to 4 hours, come back in, and then take a second dose if they were still in moderate withdrawal. And I think that has really changed. This is highlighting a case series of about 100 people. There's plenty more, this kind of starting out in around 2009 and going forward, to say this is still efficacious and safe to do inductions of this medication and start this medication at home. And the risks are just as low as when we do it in the clinic. Okay, and I think just to highlight the fact of how potentially doing it in the office is not the best way. This talks about when people kind of coming off of these substances will be starting to withdraw. So the shortest acting ones are at the top, longest acting are at the bottom. So fentanyl, just a few hours, someone will go into withdrawal. Mainly the ones that we want to think about is going to be heroin. That's going to be over a day, usually around like 24 hours. And then methadone, we're not even really thinking about starting the induction process until we pass the 72-hour mark, usually longer than that. So these are also long periods of time that are tough to sync up with getting someone in the clinic to start this medication. If they're at home, we can basically give them other adjunctive medications to kind of be treating those mild to moderate withdrawal symptoms. And then they get to start this basically in the comfort of their own home, and also not be sitting in the waiting room of an office while you're in withdrawal, which I can only imagine feels terrible. Okay, so let's check back in with Lucas. So his CALS was graded at 4. So we walked through the BUPAP with him in the office. We set up his appointment for cognitive behavioral therapy with the substance use psychologist. He had really good family support, so he went home to do the induction there. And then we gave him about a week of medication prescription, and he's going to come back in at that time and see us. Okay, so this is a big slide, but walks through that induction process that we just talked about, but how to sort of do that at home. And I think just to hit on a few of the kind of like actual numbers that we use, it's going to be starting around like 4 milligrams, and that's 4 to 8 usually. A lot of times people will get the 8 and 2 milligram strips, and they'll cut those in half while they're still in the tinfoil and be able to take half of it, wait about an hour to 4 hours. The app would then sort of like prompt them to redo their CALS. Based off of that, they would take another dose. And then if they take that now 4 and then 4 again, so 8 milligrams on the first day, then they're going to start out the next day doing either 8 milligrams in the morning or 8 milligrams in the and 8 milligrams in the afternoon, or just doing 16 milligrams once in the morning. And this medication, when it's being used for opioid use disorder, can be used as a once a day dosing. So it's super easy. These are sublingual films, so you don't even need water or anything else to swallow a pill. They're dissolving. Like I said, they're either oral dissolving tabs, sublingual films. There's buccal tabs, which basically just means they sit against the cheek. So super easy to take. And if you're doing it once a day, it is not affecting people's lifestyles. And we'll talk about that a little bit more when we think of numbers of abstinence, methadone clinics, and also buprenorphine treatment. Okay. And then at that sort of week, we talk about reassessing where people are. And I want to hit on a little bit what that looks like. Okay, so this is, these are functional MRI images. If you haven't seen these before, the ones on the far right are basically kind of like sliced down the middle, looking from the side. And all of these other ones are kind of like sliced straight across, and you're looking up from the feet. And these are, the green is going to be unactivated mu opioid receptors in the brain. And the blue shows that those are all bound, basically not active at that. Well, basically like they're bound at that point. So when we look at these numbers, this is kind of where our 16 milligrams a day total comes from. If we're at that 2 or under 16, we still have quite a few receptors that are unbound. That leaves room, well, basically more room for cravings to come in. So that 16 is really kind of like the sweet spot that we think about for most people. Most people can do that. Some people are fine on a little bit less. Some people need around 24, but we try and figure out kind of like what that is for each person. Okay, so these are the other medications that I talked about. Like I said, this is not a comfortable process for someone to wait until they're in a moderate severe withdrawal. So we need to be treating those symptoms either when they're doing that at home, it's much easier. When it's in the office, it can be somewhat difficult, but these kind of go through each one of those symptoms and treat them specifically. That's Tylenol for pain, and doing that as sort of fixed dosing. People aren't able to sleep with this, so we can use trazodone and melatonin, use loperamide for diarrhea, which is actually going to work on the peripheral opioid receptors, and Zofran for nausea, and then clonidine, which is a centrally acting alpha agonist. That one is going to help with a lot of sort of like general symptoms, the anxiety and irritability that we talked about, plus the tremor. It's going to sort of quell most of those. Okay, so this is what I wanted to break into a little bit more about, kind of like talking about abstinence treatment versus methadone versus sort of buprenorphine. And I think we do have to reframe how we think about this a little bit, and that's the harm reduction framework. It is not sort of what the classical 60s and 70s of abstinence only was, where if you need to basically just take drugs out of your life, and therefore you will be cured over time from this. And if you do drugs, then you're a bad person. It's not helpful, and it's not supported by the evidence of treatment for this. And so hitting on another reason why sort of just stopping either cold turkey or inpatient facilities that aren't using MAT, it's because of the relapse rates. So if you're in a facility that's not using MAT and you're doing, say, a 30-day program, the risk of relapse at 2 years is 80%. That's super high. That's 1 in 5. Or sorry, that's 4 out of 5, leaving 1 in 5 that sort of like stuck with it. But the idea is not only is that sort of leaving those people to go back to using opioids, but they've also decreased their tolerance in that time. So that when they do use again, this is when we see a lot of fatal overdoses. So it's abstinence only programs put people at higher risk for fatal overdoses afterwards. This is also, as we'll see a little bit later when we break into where the funding from the national and state governments are going, this is also going to be in the justice system. So incarcerated individuals, obviously just in sort of the classical US justice system, would withdraw in jail, and then basically be abstinent for some period of time, get out of jail, And that's when we see another sort of spike in fatal overdoses because they've decreased their tolerance again. So not only are these not efficacious, but we're also putting people at risk of undue harm that we know we can prevent. All right, so let's check back in with Lucas. So he's now stable at 16/4 of Suboxone a day. He's continuing cognitive behavioral therapy. We've since spaced him out to a month-long visit. And unfortunately, with his construction, he suffered a distal phalanx fracture, so he broke his finger. He's having pain from this, plus he has a planned surgery in 2 days. So what do we do with his Suboxone that he's on? So classically for planned procedures, the prescriber or the other physicians involved would pull the person off of their Suboxone, wait a few days, provide the procedure, give them short-acting opioids or something else for pain in the meantime, and then have them kind of try and restart it, getting plugged back into the clinic. We've since learned that's not the best way to do it. When buprenorphine was invented, this was kind of in, I believe, in the early 90s. It was initially an IV medication, and it was specifically for pain. So it can be dosed for pain. When we're dosing it sublingually, we just want to space that from a once a day or twice a day dosing out to an every 4 to 8 hour dosing. And it actually covers pain really well. We can even increase the total daily dose a little bit if we need to. If that's going to cover it, then it covers it. If not, we can also just use those higher affinity opioids, fentanyl, hydromorphone, also known as Dilaudid, and give them in higher doses. And if you do that, you can still displace buprenorphine and be able to get pain control effects from those medications. I think when we think about deaths that happen from when buprenorphine is involved, it's really sort of concomitant overdoses. So we don't see many where buprenorphine has killed someone through respiratory depression. It's really when it's in conjunction with other large amounts of opioids or alcohol, benzodiazepines. So you can overcome that effect. It just has to be in higher doses. This is from the California Bridge program. I'll talk a little bit more about that later, but the Bridge program is specifically for opioid use disorder in the emergency department and transitioning to the outpatient setting. Excellent guidelines that were thought about and written here. I'm not going to go into details on this. This is obviously something that like clinicians use in the emergency department when they're trying to treat pain with someone that's coming in with an acute event that was unplanned. They have acute pain. They want to treat that. These are ways to do it while leaving them on their buprenorphine. And that's some of the stuff that we talked about just a second ago, as far as using higher affinity opioids, but also using different adjunctive medications like ketamine and some other infusions that can be used in the emergency department. So it's super helpful guidelines. And this is what I touched on earlier, but there's been some good opinion pieces about not stopping buprenorphine and Suboxone when going in for a planned procedure or even during another hospitalization for a different event, urinary tract infection, pneumonia, those kind of things, continuing it and even dosing for pain when people are in the hospital. So the things on here is things we do for no reason, plus choosing wisely. So choosing wisely is a campaign through the American Board of both like internal medicine, family medicine, emergency medicine, and some other groups on really sort of a few big ticket items that we know in the US we can do better on. In the emergency department, it's talking about not getting a CT of someone's head for every sort of bump on the head, and kind of using specific guidelines and risk stratification tools there. For this one, this is one of the choosing wisely guidelines for how we deal with people on maintenance therapy buprenorphine when they come into the hospital. Okay, so that was a lot of the sort of nitty-gritty on medications, how we use those. I do want to talk a little bit about the funding for this, because we talked about this being the leading cause of death for people under 50 in the US. That's a big deal. And I think the national government has put out funding that represents how austere they think the environment is for this. And I think we have to be able to, on a state and local level, respect that. We don't often see the government use such direct and severe language, but they do in this scenario. And so we'll talk through a lot of the numbers of the funding. I think it gives a grasp of kind of where the big problems are, not only at the national level, but at the state and local level, and kind of like what projects we're working on, kind of at all those respective levels to deal with these. So this is not going back to sort of like the 70s and the 80s and 90s, what we did. This is really kind of starting in 2017. And these started with the STR grants, the State Targeted Response to Opioid Crisis. They couldn't have called it the State Targeted Opioid Crisis Response, because then the acronym would have been STOCR. So I think this one was around $970 million that was initially doled out over a 2-year period from 2017 to 2019. And it was supporting a few projects specifically to opioid use disorder. This was the hub and spoke system. When we talk about that, hubs are larger medical centers that have a pretty good in-place addiction medicine service, and basically peripheral clinics. And then the spokes are going to be something like us, a more rural area where we don't have the same support, and we get to kind of be in a mentor-mentee relationship with those larger centers. It also gave basically a goal of increasing availability of buprenorphine statewide. And sorry, when I'm talking about this one, this is from the California Department of Healthcare Services. So this was the money that we got out of that $970 million nationally to use specifically over these 2 years from 2017 to 2019. And the tribal MAT program. These are 3 things that they really want to focus on for this STR grant. And then this is why there was specifically a tribal MAT program that was, if you're only kind of hitting on 3 things, why it was so important. So again, this is rates per 100,000 people. And when we look at those across this ethnic groups, we really see Native Americans, that's what they're basically referring to when they say tribal, and they're overly affected and really seriously. So that's why those programs were getting such a large amount of the funding. So here's another sort of pictorial representation of the STR grant: increasing access to MAT, reducing the unmet need, that's getting buprenorphine out there, and with an overall goal of basically reducing opioid related deaths. This is a few of their numbers. In 2018, after the first year of STR grants, they had started around 55,000 people on MAT. They had reversed by getting naloxone packages out there, around 27,000 overdoses. So these are good numbers, and I think this was a lot of really good work that was done. This is obviously like a very wordy slide, but it just kind of shows that 970 million, around 485 million a year, and how that was kind of being doled out through the states. This one though, like we saw those numbers after the first year. When we're looking at the green, that was money spent. And then when we're looking at the blue, that was money that was just left out on the table. So when they reviewed it in 2018, there was only around $550 million that was spent out of that total 970 million. So not even really coming close. And still, this is because the system was not set up well to sort of utilize all this money in an efficacious way. They still did a lot of like very excellent work. But this says to me that we need to have a more user-friendly system because these people are out there and they're dying in mass numbers, but we need to be able to reach them in a better way that they fully understand. This is showing sort of how many people came into treatment over that period from 2017 through to 2018, really showing at the start, there was maybe around like 40,000 people. And then at the end, they're covering upwards of 120,000 people. So like I said, not using all of the funding that was there, but really saving a ton of lives. Okay, so then when we transitioned out of that sort of 2017 and 2019 period, they changed the name on some of the grants because they were brought in kind of in the middle of that. And this is the SOAR, or the State Opioid Response Grants. And this was, again, focusing on some of those projects that they felt like needed more support and could be efficacious. So this was a couple goals of increasing access to MAT, reducing that unmet need, and then reducing opioid overdose deaths. All right, so these were the projects that they namely supported during that time. California Bridge is one where we're starting Suboxone and buprenorphine in the emergency department and getting them plugged in with someone like us that is basically that spoke. This is supporting that whole hub and spoke system to give money and support to that mentor-mentee relationship. This is focusing on MAT in the county criminal justice system. So again, we talked about people withdrawing, becoming abstinent during their time in the criminal justice system, and then increasing their risk for fatal opioid overdose death when they get out. So that was why the focus was there. And then again, we saw those numbers of the Native American population being disproportionately affected throughout the US and definitely in California. So that's why there was the focus on the tribal MAT program. This was under the STR and the SOR grant, and this was called the California MAT Expansion Project. So here's some of those numbers for California. The DHCS is the Department of Healthcare Services for California, and just talking through a couple of what those MAT expansion projects look like and their main foci. There was 1.0, there was 2.0. There's a lot of different names to these. Okay, here's a pictorial representation of where all of that money is going. And then we're coming into 2020. So they announced in 2019, this is the SOR2 grant, the SOR2. This is what we are working with now. So this is 210 million over 2 years, 2020 to 2022. We are working through this funding, very similar goals to the California MAT expansion project. Okay, so I had the opportunity to come in and help steer the ship of what we're doing and how we're trying to deal with opioid use disorder treatment in South Lake Tahoe. But I definitely did not start this process. I want to talk about a little bit of the team that we have locally. And so the previous director was Matt Wanacott, who is now our hospital's CMO. He had really started some of the relationships with El Dorado County Opioid Coalition, Excel, Access to El Dorado, and Marshall Hospital, who have been really helpful in kind of getting us up and running and giving us the tutelage that we need to get this started. Drew Herbert is one of the nurse practitioners at the Barton Community Health Center. He has taken a large burden of the opioid use disorder population and has been dealing with them since he came here. He has been absolutely excellent and is going to be a huge part of this going forward. Robert Randolph is part of our population health, and he is kind of helping us hit the metrics that we need as we kind of get doled out the money coming from the SOR2 grant to help us with this. There's a couple other practitioners that are in the Barton Health system, namely the Barton Community Health Center. That's going to be Grace Harding, Elka Hauser, Sierra Armstrong, and Kim Orta. They're also going to be prescribing Suboxone and buprenorphine. And then we have an emergency room bridge program that is getting separate funding through the ED Bridge, and that's mainly run by Dr. Elizabeth McNamara, who's one of our ED physicians and is very interested in this topic. And then recently, she has hired Azzy Suave, and she is our substance use navigator, so helping people get through the system of kind of getting bridged from the emergency department to our BCHC, Barton Community Health Center MAT program and what that looks like, and then making sure that they stay plugged in and we have appropriate follow-up. All right, let's touch back in with Lucas. He comes in, he gets his monthly urine drug screen. It's positive for amphetamines. So what do we want to do with this? I think, again, this has really changed how we think about this. These are not punitive urine drug screens. They are to see how someone is doing. Is there an unmet need? And then basically, it is not a reason to stop prescribing this medication. They still have opioid use disorder. We are still treating a specific disease process. Just because there are lapses, like these are expected, they're not punitive. Okay, I'm just going to touch really quickly on what our bridge program looks like, so you guys can get a little bit familiar with that. So there's been a lot of research coming out in this area, and there's been some strong position statements made. CDC is basically like, start these, get access to buprenorphine. Part of the California MAT expansion project is putting into the curriculum of every emergency physician when they go through residency that they have to have training on buprenorphine. So that started in 2019, and that'll be big going forward. These are a few larger medical centers that are using a bridge program and doing that really well. Our closest one is Highland Hospital there. That's kind of like, that one has made national news for their bridge program. So here is the algorithm that they use specifically in the emergency department. They use a faster dosing scale and a little bit higher. So it's usually 8 milligrams, wait an hour, and then see if they can redose, but they're still using the CALs and adjunctive medications, very similar to the office-based. And once this has been finished, they're trying to get them plugged into the clinic. And this is why. So there's an exemption to the DEA rules surrounding the prescribing of Suboxone and buprenorphine. And that's really because there are not enough prescribers at this point. It is, and on top of medical school and residency, it's something else that you have to do to be able to prescribe buprenorphine and Suboxone. And not everyone's going to do that for various reasons, and we'll talk about that in a second. But there's a 3-day rule where they can basically give buprenorphine in the emergency department for 3 days, 72 hours, not write a prescription, but they can give those, trying to bridge someone to a clinic visit. This is a little bit of the research supporting bridge programs. They improve outcomes. If there's Suboxone started in the emergency department, they have about an 80% chance at 30 days of sticking with it. If they do not give it, or they just give them a brief like talking intervention, the numbers are about half that. They're around 40%. It's cost effective. So of the patients that are getting buprenorphine in the emergency department and getting bridged, we see because of that sort of like 40% versus 80% that are sticking with it in 30 days, there's a lot of down the line healthcare costs that are recouped. Okay, so really quickly, just some barriers that do remain with this. People still, physicians, nurse practitioners, PAs still have to get X waivered to be able to prescribe these medications. That's going through a separate course to be able to do this on top of everything else that they already do. The Department of Health and Human Services put out a memo in January saying they were repealing this law, and that was going to change. However, that was put out on January 14th. On January 27th, that was pulled, and they said they're going to reevaluate this change and hopefully decide when that will happen. But that is something that I believe will happen. I just don't know the time frame on it. Okay, so a few barriers that do remain. These are some perspective pieces that talk about where we're going with addiction medicine in the United States. And I think the idea is that this needs to get out to more people, and primary care is going to play a huge role in that. These clinics that are able to prescribe buprenorphine. So some of the myths that still exist is buprenorphine treatment is more dangerous than other chronic medications and management thereof. We already talked about its inherent safety profile and that it already has a combo medication to increase that even further. I think a lot of physicians are willing to reach across the aisle and treat basically diabetes, hypertension, other things. This is something that I feel should be expanded to all specialties. Okay, is buprenorphine simply a replacement for the addiction? No, we already talked about kind of defining what opioid use disorder and addiction is, and it's really taking that drug despite harm. If you are taking something to manage a chronic medical problem, say your antihypertensives, you are not addicted to those, you are using them for a benefit. We talked about this other myth here, detoxification for opioid use disorder is effective. We know that is not true if it's not done in combination with MAT. And not only is it not efficacious, it also puts people at higher risk of undue harm. So prescribing buprenorphine is time consuming. We're hoping to reverse that very soon with some of the changes to the legislation. Reducing opioid prescribing alone will reduce overdose deaths. From the numbers, we know that not to be true. We already talked about them increasing 18% in 2020, now around 220 per day, even though since the late 90s, with sort of starting all of this, we have curtailed our prescription of opioid from clinics, hospitals, from everyone, but deaths continue to rise. All right, so to end it on our case, Lucas, at the 2-year mark, remains stable on Suboxone. He received admission to law school, and he plans to fight for opioid use disorder treatment reform at the national level. So it's a happy ending. And I think our overarching goal is really going to be to reduce opioid use disorder related morbidity and mortality in South Lake Tahoe. I'm extremely excited about this. We have a really good group going forward, and hopefully we can make some strides. Some resources and sources, and then I'll open it up to some questions if we have those. Thank you guys for the time.
Thanks, Dr. Marquette. I'll just remind the attendees that if you do have questions, you can ask them in the Q&A box or in the chat box, whatever is easiest. And I'm just going to quickly mention that you had mentioned during your presentation, Excel Access El Dorado. They are hosting a opioid summit coming up on Wednesday, March 24th. From 10 a.m. to 2 p.m. So if you're interested in attending that, I think the best way to access that would be to go to their website, accesseldorado.org, and you can click to their Facebook page, and on their Facebook page is the direct link to register for the Zoom virtual presentation. And Dr. Marquette, I didn't know if you wanted just to touch on Narcan, maybe what that is, what that does, and how people can access that in our community.
Yeah, so Narcan is going to be a similar formulation of naloxone not in pill form. It's going to be packets of basically mainly nasal sprays that can be used to help if someone is having an overdose and they have respiratory depression, to be able to use that intranasally at home. And this is usually given out to, we prescribe it with most people that are on chronic narcotics, and it's something that can be used by family and community members.
Great, thank you. I know, I do believe El Dorado County, the Substance Use Disorder Office, which is located at 1900 Lake Tahoe Boulevard, right across, actually from, I think, one of the breweries just down the road, that they offer free kits as well. So if someone has a concern for a family member or a loved one, they can access it there as well. And then just to touch on someone who is part of the MAP program, is that something they'll always be a part of, or what's the long-term goal for someone who's
Yeah.
program?
So I think classically it would be sort of trying to get some point of stability, maybe 1 year, 2 years, and then try and taper that person off of the medication. However, as most of the evidence comes out, we see that this is something that a lot of people do really well on longer term, and have better outcomes if they stay on it. So for a lot of people, it's similar to blood pressure medications, diabetes medications, where they will likely be on this for life.
Great. And there's a question that's come in asking if any of these medications help people with alcohol use disorder.
For alcohol use disorder, there's 3 that we namely use in the US. One of them is naltrexone, which is very similar. So that one's going to help with cravings as well. There's also a camprosate and antabuse that we use. So a little bit different as far as like what we're going to use when we're trying to treat those specifically.
Great. That looks to be as the questions that we have tonight. And I know we're right at the top of the hour. So I think I'll go ahead and wrap it up unless there's anything else that you wanted to add before we adjourned this webinar.
No, that sounds great. Thanks for the time.
All right. Thank you so much. I hope everyone has a nice evening.